This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending here, and it is a pleasure to be back in the studio discussing the literature that shapes our operating rooms.
And I'm Dr. Alara, a research fellow. Today we're looking at a fascinating new study from the journal Child's Nervous System, published in February 2026. It's a prospective, multinational cohort study titled Preoperative Hydrocephalus and the Risk of Postoperative Speech Impairment Following Posterior Fossa Tumor Surgery in Children.
This is a big one, Ilara. Anyone who has spent time in pediatric neurosurgery knows that the posterior fossa is a high-stakes neighborhood. We're often dealing with medulloblastomas, astrocytomas, or ependymomas. While we've made incredible strides in survival, the morbidity, specifically cerebellar mutism syndrome, or CMS, remains a ghost that haunts our postoperative rounds.
Exactly. And for the residents and students listening, just to recap, the cardinal symptom of CMS is postoperative speech impairment, or POSI. It ranges from a total loss of speech to a significant reduction in output, often accompanied by emotional lability and ataxia. For a long time, we've looked at things like tumor histology, size, and involvement of the vermis as risk factors. But this study zooms in on something that affects up to 70% of these kids before they even hit the table: preoperative hydrocephalus.
It's a logical question. If you have significant ventriculomegaly and increased intracranial pressure before you even make the skin incision, does that prime the brain for a worse outcome? Let's look at the study design. 800 children? That's a massive cohort for this field.
It really is. They pooled data from 35 centers across 13 countries through the European CMS Study Group. The timeframe spanned a decade, 2014 to 2024. They were very specific about how they categorized things. They looked at the presence of preoperative hydrocephalus, how it was treated, and then tracked speech outcomes as habitual speech, reduced speech, or mutism.
I like that they didn't just use a binary mutism or no mutism label. In clinical practice, we see a spectrum. There are kids who aren't fully mute, but they're clearly not themselves. Their prosody is off, their initiation is slow. That reduced speech category is vital for a nuanced understanding of surgical morbidity.
Right. And the big clinical question they tackled was, does alleviating that hydrocephalus before the tumor resection actually help? We're talking about the age-old debate of the preoperative ETV, endoscopic third ventriculostomy, or a shunt, versus just going straight for the tumor and letting the resection deal with the CSF flow.
Every attending has a different philosophy on that. Some say get the pressure down, let the brain settle for 48 hours, then go in. Others say, why do two procedures when one will solve both problems? What did the data show regarding the hydrocephalus itself as a risk factor?
Well, the study found that preoperative hydrocephalus is indeed a significant marker, but the nuance lies in the severity and the persistence. When they looked at the 800 children, they found that those who presented with high-grade hydrocephalus had a higher incidence of POSI. But here's the kicker. Simply alleviating the hydrocephalus prior to the main surgery didn't necessarily wash away that risk.
That's a critical point for the residents listening. It suggests that the damage might be done, or at least the pathway is set, by the time the patient presents to the ER. The mechanical stretching of the white matter tracts, perhaps the pressure on the efferent cerebellar pathways like the dentate rubrothalamic tract, might already be at a tipping point.
Exactly. The researchers looked at PHC treatment, categorized as yes, pre-resection diversion, or no, resection alone. In their multivariate analysis, once they adjusted for things like tumor location, specifically whether the tumor was midline or involved the floor of the fourth ventricle, the act of preoperatively treating the hydrocephalus didn't significantly lower the rate of mutism compared to those who had their hydrocephalus managed by the resection itself.
This supports a growing trend in our field toward more direct management. If the pre-op ETV doesn't definitively lower the risk of CMS, many surgeons would prefer to avoid the extra procedure and the potential risks of infection or CSF overdrainage before the main event. However, we have to be careful. This doesn't mean we never treat hydrocephalus first. If a kid is herniating or in a coma from pressure, that's a different clinical scenario.
Definitely. This study focuses on the risk of speech impairment, not necessarily the emergency management of ICP. But let's talk about the why. Why does hydrocephalus correlate with POSI at all?
I suspect it's a surrogate for the degree of distortion in the posterior fossa. If you have enough hydrocephalus to be clinically significant, you usually have a tumor that has completely obliterated the fourth ventricle. That means more tension on the brainstem, more displacement of the cerebellar nuclei, and more difficulty finding a clean plane of dissection. Ilara, did the study mention anything about the histology?
It did. They tracked histology at the 2-month follow-up. Unsurprisingly, medulloblastomas were heavily represented in the POSI group. But the study emphasizes that preoperative hydrocephalus should be viewed as an independent red flag. It's a marker of a more vulnerable cerebellum.
This is great for our preoperating counseling. When I'm sitting down with a family, I'm already looking at the MRI. If I see massive ventricles and a thinned corpus callosum, I'm now going to be even more cautious in how I describe the recovery period. I might say, because of the pressure that was present before we even started, your child's brain is at a higher risk for this temporary speech difficulty.
And that brings up the habitual speech versus reduced speech data. For the medical students listening, it's important to realize that POSI isn't always silence. Sometimes it's a child who can only say 1 or 2 words, or who has a very flat robotic tone. The study showed that even in cases that didn't meet the full criteria for mutism, preoperative hydrocephalus was a predictor for reduced speech.
It's a spectrum of injury. We often focus on the all or nothing of mutism because it's so dramatic, but reduced speech can be just as frustrating for a family and can signal the same underlying disruption of the cerebellar cortical loops.
One of the strengths of this study is its prospective nature. In many previous studies, we were looking backward, trying to remember if a patient was mute or just quiet. Here, they had standardized speech assessments before and after surgery. That really cleans up the data.
It does. But let's play devil's advocate. If I'm a resident and I see this paper and I see that PHC treatment, meaning preoperative EVD or ETV, didn't change the outcome for POSI, should I conclude that pre-op CSF diversion is useless?
I think the authors would argue that it's not useless, but rather that it isn't a protective factor against CMS. You do an ETV to save a life or to make the brain more relaxed for the approach, but you shouldn't tell the parents, we're doing an ETV to prevent him from becoming mute. The data just doesn't support that.
Well said. It's about managing expectations. Now, did they mention the timing of the POSI? Usually it's not immediate, right?
Exactly. In most cases, there's a lucid interval of 24 to 48 hours where the child might actually say a few words and then they slip into the mutism. This study confirmed that pattern across the multinational cohort. The presence of preoperative hydrocephalus didn't necessarily change that delayed onset, which suggests that CMS POSI is a secondary phenomenon, likely related to edema, perfusion changes, or axonal metabolic crisis following the decompression.
It's almost like a reperfusion injury of sorts, or at least a radical shift in the internal milieu of the posterior fossa. You take away the tumor, you take away the hydrocephalus, and the brain has to recalibrate. If it was under high pressure for weeks, that recalibration is much more violent.
So what's the take-home for our practicing neurosurgeons?
First, recognize that hydrocephalus is not just an incidental finding we fix, it's a prognostic indicator. Second, don't feel pressure to perform a preoperative CSF diversion solely in hopes of preventing speech issues. It won't help that specific problem. Focus on a meticulous atraumatic resection, especially near the floor of the fourth ventricle.
And for the researchers out there, this study opens the door to looking at DTI, diffusion tensor imaging, to see if we can actually visualize the white matter strain caused by that preoperative hydrocephalus. If we can quantify the strain, maybe we can predict POSI even more accurately.
Great point. This 2026 study is a massive step forward. It uses the power of a multinational cohort to give us answers that a single center just couldn't provide. 800 patients is a lot of data points, and it brings a lot of clarity to a very difficult complication.
It definitely makes me want to look closer at the reduced speech patients in our own clinic. Often we call them successes because they aren't fully mute, but they still have a long road of speech therapy ahead of them.
Precisely. Well, Ilara, I think that covers the essentials of this paper. Any final thoughts?
Just that it's a reminder of how much we still have to learn about the cerebellum. It's not just about balance, it's about the very essence of how we communicate.
Beautifully put. Thank you all for tuning in to the Neurosurgery Hub. I'm Dr. Aris.
And I'm Dr. Ilara. We'll see you next time.
Keep operating, keep learning, and keep questioning the literature. Goodbye for now.